Hello and welcome to the recording of Delivering Integrated Care for CRM, Early Detection and Intervention in Practice webinar. Our expert speaker, Donna Sutton, lead community diabetes specialist nurse from Newcastle upon Tyne Hospital's NHS Trust, explores the latest developments in CRM and what they mean for long-term care planning. For further free content, please visit www.sbk-healthcare.co.uk. Thank you, and I hope that you found this webinar educational and enjoyable.
Hello everyone and welcome. My name is Donna Sutton and as Lara said, I work for Newcastle upon Tyne Hospitals as their lead community diabetes specialist nurse, and I'm delighted to spend this lunchtime with you exploring the cardio-renal metabolic spectrum, which is a cluster of conditions that we see every day in primary care. I just want to say thank you to SBK for hosting me. I have no disclosures. So today's session is all about supporting you to improve outcomes, to reduce hospital admissions and deliver truly integrated care. So by the end of this webinar, you'll understand the latest developments in CRM and how they shape long-term care planning, explore both pharmacotherapies and lifestyle interventions that are reshaping treatment, and demonstrate examples of what works in real-world settings. So why does CRM matter? So cardio-renal metabolic disease refers to the interconnected nature of cardiovascular disease, chronic kidney disease and metabolic disorders such as type 2 diabetes and obesity. These diseases are very closely linked with each other, and it's important that we look at them as a whole and not as individual diseases due to the interlinking nature of these. The reason for this is that up to 60% of people with chronic kidney disease also have cardiovascular disease. And in the UK, people with heart failure, about 60% of them have chronic kidney disease also. In the UK, approximately 30% of people with type 2 diabetes have chronic kidney disease. And approximately 1 in 3 people with type 2 diabetes have cardiovascular disease. And we estimate between 20 to 40% of people with heart failure have diabetes as well. So this demonstrates the interlinking of all three diseases as well. So we talk about the common soil. So the concept of the common soil helps us understand why these diseases so often coexist. We have insulin resistance, which leads to endothelial dysfunction and atherogenesis. We have chronic inflammation and oxidative stress damage the kidneys, and renal impairment raises cardiovascular risk further, and so the cycle continues. So when we see a patient with diabetes and rising blood pressure or new microalbuminuria, it's not a separate problem. It's the same pathology showing up in different organs. Understanding this helps us move from disease-specific care to system-based care, where our goal is to protect the whole cardio-renal metabolic axis. They all share common risk factors: insulin resistance, obesity, hypertension, inflammation, and together drive a vicious cycle of declining health. In the UK, more than 5 million people live with type 2 diabetes, and around 40% of them will develop chronic kidney disease, and up to half will experience cardiovascular complications. For our patients, this means reduced quality of life, increased admissions, and shorter life expectancy. For the NHS, it means soaring costs and a growing need for proactive, integrated management. So as primary care clinicians, we have a huge opportunity to intervene early, coordinate care, and prevent progression. So in primary care, we can catch deterioration early if we know what we're looking for. So things such as rising HbA1c despite good adherence to medication. Microalbuminuria, where their ACR is rising above 3 milligrams. EGFR trending down, even with it being within a normal range, worsening blood pressure control, weight gain, or increased central weight gain. So thinking about those diabetes annual reviews, these are the perfect opportunity to integrate cardiorenal checks. Ask yourself, is this patient at risk of progression? Should we adjust medication, intensify lifestyle support, or even refer to specialist services? Or all of the above? A practical tool that we have is the KDIGO risk grid, which categorises patients by EGFR and albuminuria, which is useful for stratifying chronic kidney disease risk. And the KDIGO heat map is a useful tool in assessing the risk of kidney disease in individuals. It uses basic results such as the EGFR and the urinary ACR measurement, and these evaluate the risk of kidney disease progression and kidney failure. The numbers on the grid, they refer to how often we should be monitoring the frequency of EGFR and albuminuria. I use this as a tool with my patients as well to help them understand what we're talking about in terms of what their EGFR is and what we're checking for in that urine sample that we're always chasing them for. It helps them to clearly see when we have something in front of them to show them why we're interested in these numbers and why it's important for them to try and halt that progression of proteinuria. We have other tools as well, so the ones that are at our disposal that can help with early detection and treatment decisions. There's the kidney failure risk tool, which is recommended by NICE. This tool is used for patients with stages 3A to 5 chronic kidney disease to predict the probability of needing kidney replacement therapies such as dialysis or transplant within 2 or 5 years. It takes into consideration their urinary ACR, their sex, their age, and EGFR, and can calculate the projected risk of kidney failure. We also have the QRisk3 tool, which is an online tool to estimate an individual's 10-year risk of having a heart attack or stroke. It's a cardiovascular disease risk assessment tool that uses a complex algorithm based on factors like age, sex, ethnicity, BMI, blood pressure, and cholesterol levels. Using the tools is important. What's even more important is early intervention. This is key. The UK PDS study and looking back over that 35-year later, the median of 10 years follow-up demonstrated that every 1% drop in HbA1c in adults with type 2 diabetes was associated with a decreased absolute risk reduction of complications. For example, a 12% reduction of the risk of going on to have a stroke, 16% reduction of having heart failure, a 14% reduction in myocardial infarction, and a 14% reduction in all-cause mortality, and a 21% reduction in death related to diabetes by that 1% drop in H1C. So it's really key to get that intervention in there early. And this graph, taken from that retrospective study, looks at the late glycemic intervention results in what we call a bad glycemic legacy. So what we have here is on the upper dotted line, highlighted here, that's represent the time course of H1C estimated on the basis of the average glucose profile described by the UK PDS study. And in the lower dotted line represents the ideal time course of glycemic control, with the solid line representing the time course of H1C and the VADT. So what this demonstrates is that early intervention within the first few years of diagnosis really does have that legacy effect, you know, lasting 10, 15 plus years of reducing that risk of complications from diabetes. We also have national and international guidelines to help support our decision-making tools, such as NICE, or MG28. We have the ADA and the ESD as well for managing our type 2 diabetes, and we use parts of those. And then for chronic kidney disease, we have access to KDIGO guidelines and the UKKA guidelines as well. And for cardiovascular disease, we look at the ESC and the AHA guidelines. But interestingly and importantly is that they all recommend early use of SGLT2 inhibitors alongside standards of care for cardiorenal protection. So in the last years, with the introduction of SGLT2, been around about 10 years now, but for cardiorenal metabolic conditions and that management, we have a drug class that delivers cardiovascular and renal protection beyond glucose lowering, with the key player being dapagliflozin, empagliflozin and canagliflozin. These are proven to reduce hospitalization for heart failure, the slow chronic kidney disease progression, even in non-diabetic chronic kidney disease as well, with a proven mortality benefit. And we would recommend this early, as soon as the EGFR allows, or as the EGFR allows. And with the new NICE medication guidelines, hopefully due in about February next year, this will be key of getting SGLT2 in there for all classes of people with type 2 diabetes. We also have GLP-1 receptor agonists such as semaglutide, liraglutide and dulaglutide, and these have been exceptional in promoting weight loss and helping with glycemic control, but also reducing major adverse cardiac events. They're excellent for obese or high cardiovascular risk patients, and now we have the benefit of dual agonists, GLP-1 and GIP, in the terms of tirzepatide, which again is shown in studies that it, with head-to-head with dulaglutide, is beneficial for heart protection as well. We also have ACE inhibitors and ARBs, which remain foundational for blood pressure management. Both ACE inhibitors and ARBs work well to lower blood pressure and treat conditions like hypertension, heart failure and chronic kidney disease. And they all work on the same renin-angiotensin-aldosterone system. The aim is to start early, titrate to maximum tolerated dose, reduce the albuminuria and protect the renal function as well. We also have the introduction of finerenone, which is a non-steroidal selective MRA, which in clinical studies showed that in patients with chronic kidney disease and type 2 diabetes, treatment with finerenone resulted in lower risk of chronic kidney disease progression and cardiovascular events than the placebo. NICE recommends finerenone as an add-on to optimise standard care. So if someone has type 2 diabetes and chronic kidney disease with an eGFR above 25 and a urine ACR above 3, and they're on both maximal tolerated either ACE or ARB plus an SGLT2, unless otherwise not tolerant. So we need to be thinking more about adding the finerenone in as well. So in practice, what does this mean? That when we diagnose someone with type 2 diabetes, don't just ask, what is their HbA1c? We're not just looking at that glucose, but we're also asking ourselves, how's their kidney? How's their heart? And choose therapy accordingly. And is that having that conversation with our patients as well about getting that intervention in there earlier, making them understand that because of these diagnoses of hypertension, of kidney disease, of type 2 diabetes, that yes, you're going to need medication for this, but letting them understand what that medication does. A lot of issues around concordance with medication and people don't like taking medication is that they don't fully understand what it is actually doing. So having that time and spending that time with your patients to help them understand really is important as well. Medication is vital, and we need to ensure that we have that resource there, but lifestyle remains the cornerstone as well. We know that even just modest weight loss of 5 to 10% can significantly improve metabolic and cardiovascular outcomes. Areas to focus on: diet quality. So for cardiorenal metabolic syndrome, a diet emphasizing fruits, vegetables, whole grains, lean proteins and healthy fats is recommended, which can be similar to things like the Mediterranean diet or the DASH diet. The DASH diet is the dietary approach to stop hypertension. Key recommendations from them include limiting salt, limiting saturated fats, limiting adding sugars or using processed foods, and paying close attention to protein and things like phosphorus intake, especially when you have chronic kidney disease as well. Use a dietitian if you have that resource to help with that lifestyle management as well. We should be encouraging more activity into our day or week for all our patients. And the recommendations is that we should be incorporating at least 150 minutes of moderate intensity activity a week. And we know that even doing that can reduce insulin resistance and blood pressure. And given some examples of how people can fit that into busy day-to-day lives, it can be broken down into small 10-minute portions, and it doesn't necessarily mean doing exercise. Determine the difference between activity and exercise as well, because sometimes if you mention exercise to people, they think of doing bungee star jumps and things like that, and joining the gym and doing all that sort of things. And that's not always possible for people for enjoyment's sakes or for budgets. It's about getting that activity into your day, utilizing tools that are available, YouTube videos, things like that. The NHS app also has some good examples to share with your patients. Smoking cessation, sometimes it's overlooked, but it's really essential that we get that support in there, and it's helpful for that renal and vascular protection as well. They say that it takes about 16 attempts to finally stop smoking. So if people have said, oh, I've tried it and it's never worked for me, that's just their first step to stopping smoking. So really do encourage them as well to keep going. And again, sleep and stress management. Both of these things both influence our metabolic control. And the Leicester Diabetes Centre done some really good work on the 5 S's in managing type 2 diabetes. And the aim is for consistent, uninterrupted sleep. More than 8 hours and less than 6 hours of sleep negatively impacts HbA1c. So again, asking our patients about what the sleep time is, their quality. Irregular sleep patterns results in poorer glycemic levels, and this could be due to things like insomnia, obstructive sleep apnea, and restless leg syndrome. People that are night owls, so people who go to bed late but get up late, research has shown that they may be more susceptible to inactivity and poorer glycemic levels compared to people that are classed as early birds who go to bed early and get up early as well. But behaviour sport is where practice nurses really do excel. Motivational interviewing, realistic goal setting and consistent follow-up, really to help people make lifestyle advice actionable rather than aspirational as well. So let's look at a few case studies. So here we have John, who has type 2 diabetes and has been diagnosed for approximately 5 years. He's aged 58 and has hypertension. He is obese. He's a non-smoker but works as a delivery driver. And his BMI is 31. His H1C is suboptimal at 60. His blood pressure is raised at 140/70. His eGFR is 63. And his urinary ACR is at 15. His current medication, he's taking the atorvastatin. He's on ramipril, amlodipine, metformin, glucoside, and sitagliptin. So what concerns will you discuss with John? And are there any treatment changes you would suggest for him? The first thing is, asking John, what is your concern? Do you have any concerns about your diabetes or about your blood pressure or about your kidneys? Do you realise about your kidneys and that you're leaking some protein? Not everybody is aware of all these things. We're very good at giving our patients all the information, and they have access to that now via the NHS app, but do they actually understand it? Because a lot of people feel well and they don't understand why we as clinicians are then saying, you need to take these tablets. It's really important to take these tablets. And we need to see you more often. We need to take more blood from you. Why? I feel well. And, someone that works in the Northeast, and the normal response that I get is, I feel champion. I'm all right. So whatever that response may well be from wherever you work. So it's about having that conversation about, what is diabetes to you? What is hypertension to you? A lot of people, they generally know what their blood pressure should be, but they don't actually know what the blood pressure is. So having that simple conversation and breaking things down. A lot of people think that we're asking for the urine because we're looking for sugar in the urine. And, what are we looking for and why are we looking for these things? Looking at his numbers there, he has suboptimal diabetes control. And someone that's on medication, and we are looking for that H1C to be as close to 48 as possible. And we're looking at that longevity of his diabetes. He's had diabetes 5 years now. Now, we don't know how long he was living with diabetes before we caught that as well. So people can live for years sometimes with undiagnosed diabetes. And we know that, and we estimate there's over 1 million people at the moment in the UK walking around without having a diagnosis of type 2 diabetes. So we've got that longevity of diabetes, and thinking to that UK PDS study of getting intervention in early, getting that optimal diabetes control early ensures that legacy of minimising those complications later in life. We also need to think about his hypertension. His blood pressure is still elevated, despite being on an ACE and on a calcium channel blocker as well. We need to think about his kidneys and the fact that he is got microalbuminuria and how we're thinking about protecting that. So medication-wise, we could start thinking about SGLT2 for John. I think that would be a good option to speak to him about that. But also we need to take in consideration his lifestyle. We need to explore that as well. He works as a delivery driver. Does he do any other activity? As a delivery driver, he may spend a lot of time sedentary, and we need to try and minimise the amount of time that we are sedentary for. So having that conversation with him, addressing diet, is there room for manoeuvre? Looking at that saturated fat in his diet, is there lots of vegetables in there? Have we got a good mix in his diet as well that will help? All these options there for him of where we can manage, but it's again giving all that information to John, and what John understands from this information is really, really important. Rather than just your numbers are high, we need to add another tablet, and more tablets tend to lead to less concordance with taking those medications, as you would expect that as well. And then we have Benita. So Benita is 60 and has just been diagnosed with type 2 diabetes last year. She has had hypertension for the last 3 years. She's from an Afro-Caribbean background, non-smoker, and works in an office. Looking at her numbers, her BMI is 28, H1C suboptimal at 64, blood pressure 130/70, with her EGFR and urine ACR reading as normal. Her Q-risk score is at 10%. Her current medication is she's on ramipril and metformin. Again, same questions. How do we approach Benita? What are we wanting to think about? What concerns have we got? And what concerns has Benita got? Has she got any concerns? Does she understand those risks of having type 2 diabetes? And has she had any sort of structured education about understanding and managing her diabetes? And that's always key to come back to that as well. You know, even if someone has been diagnosed for many years, they might not have been ready or been offered structured education at the very beginning. So if you have that ability to have that conversation with on that annual review of, you know, there is structured education available, you know, that will help you understand your diabetes a little bit more and how to manage that. It may well be, you know, revisiting that as well. So we need to think of early intervention is really key here. We're within that first year of diagnosis. We really need to get on top of diabetes and letting Benita aware of that as well, so that she understands why it's really key that we really try and work with her to manage her health. So obviously our H1C is suboptimal, and we're looking for that longevity to minimise that bad glycemic legacy as well. Her blood pressure, she has got hypertension and she's on an ACE for that. But as we know, the lower the better with blood pressure and hypertension. So we need to try and look at that as well. In terms of her Q-risk score, so we should be offering atorvastatin for primary intervention with a Q-risk score of 10% or more. She has got that cardiovascular risk because of her weight, her ethnicity, her type 2 diabetes, her hypertension. So we really need to make sure that we're putting all those protective factors in there as well. So we'd want to discuss a statin such as atorvastatin with her. Again, SGLT2s, you know, getting in there early. Nice guidance at the moment. You know, if there is a cardiovascular risk, you know, get them started on metformin, get them to the highest tolerated dose, and then straight in with an SGLT2. No hanging about, no waiting for the next review, no waiting for the next H1C, straight in with the SGLT2 as long as the EGFR allows for that. So we would want to talk about that as well. And that's a lot when, you know, she's just been diagnosed within that year. She's already taken 2 different medications, and we are now talking about 2 more medications with Benita. So it really is, education is key for her as well. But we also need to explore her lifestyle. You know, has she got quite a stressful job, family life? Is that interrupting her sleep pattern as well? We see that she's an office worker. Is that quite sedentary as well, that job? So does she manage to get activity planned into her day as well? And looking at diet, you know, can we have we got access to be able to refer to a dietitian to be able to give her that extra support, or can we do that through structured education or looking at the resources we have available within clinic, such as looking at NHS websites. Carbs and calories is always a go-to for me, you know, using the world foods or just your carbs and calories as well, looking at different carbohydrate contents and making people understand as well. A lot of people don't understand the carbohydrate contribution to glucose levels. They always will say to me, well, I'm not eating biscuits and sweets and cakes, but then when you address what they eat, you know, for breakfast, lunch, or evening meal, or snacks, you know, that's when they start to understand those differences as well. It's a lot to think about, a lot of things to think about in yourself, a lot of things to explore with your patients. Not a lot of time in your appointments. I do appreciate that. So it's about, getting to those core things as much as you can, as quickly and as effectively as you can as well. And that's, again, I suppose, where structured education comes in, because there is that opportunity to have that longer delve into what diabetes is, so people can understand that a lot more as well. And then across the country, we've seen great examples of how people embed cardio-renal metabolic care into their own practice. Some ideas that have came up, nurse-led virtual chronic kidney disease clinics, reviewing at-risk patients quarterly, so that you're really seeing those difference. Integrated MDTs, sharing reviews. Using your pharmacist to support with medication optimization. Some companies doing optimization for looking at the change in medication, or looking at your dashboards, identifying people who might benefit from certain medications, such as things like SGLT2s, GLP-1, especially now with the weight management side of things, identifying those people and approaching them as well. In my practice in Newcastle, we do similar things as well. So I have a monthly meeting with the heart failure specialists, and we discuss people that they are wanting to start on an SGLT2 that have type 2 diabetes. So we've got that shared information so that I can follow them up in case they need some adjustment to their own medication because of the glucose lowering benefits from SGLT2. They may need a change in the current medication that they're already on for their type 2 diabetes. We also have monthly clinics within GP practices that are attended by a specialist nurse like myself, a specialist dietitian, practice nurse, and a pharmacist. Sometimes it can be a bit overwhelming for a patient to come into that room with the four of us sitting there, but actually the takeaway from that is that the patient's getting an overall really good look at the complex condition and identifying any issues. And then we can then signpost to more individual and further follow up with a dietitian or with the practice nurse or with myself later as well. So there's lots of different things we can do within our clinics to try and identify these people and support them as much as we can. And sharing those ideas, sharing within your areas, and as well as, sharing them wider as well, so that we can all benefit to be able to pass that information on to our patients as well. As evidence base continues to grow, new combination therapies, remote monitoring, and even AI-supported risk predictions are emerging. But the biggest change will come from how we think, moving from disease silos to integrated, person-centered management. Primary care is uniquely positioned to lead this change. We know our patients, their families, and the barriers, but by embedding cardio-renal metabolic best practice, we can help to reduce admissions, improve survival, and make long-term care more sustainable. So to summarise, cardio-renal metabolic conditions are interconnected. We need to ensure that we're treating the system, not the symptom. Early detection and proactive management do save lives, and that is backed by research. Try not, we'll give you 3 months, see what you can do in 3 months. We need to empower our patients, give them that information so that they know that this is the reason why we need to get you on this tablet now, not in 3 months, not in 6 months, not in a year. We need you on it now to help prolong your life and keep you living healthy for longer. And we've got the new pharmacotherapies, such as SGLT2s, GLP-1s, embedding those into normal practice. And with the new NICE guidance coming out in February, we're going to see a use of that a lot more. Using lifestyle and patient empowerment, really, really fundamental, always coming back to those things. They should be running throughout all conversations with our patients about how we can support them, how we can manage that change, day to day with them as well. And using their teams, don't just sit in your own little speciality. Reach out to your specialist teams, reach out to your diabetes specialist, your heart failure specialist, your kidney specialist, and come to a way of how we can work as a multidisciplinary team, using your pharmacists, your dietitians. All those people have got lots of, great knowledge and expertise that together we can really, really offer a lot of support to our patients. Thank you very much for listening, and I'm happy to take some questions.
Thank you so much, Donna, for your presentation. And we do actually have some questions in the chat box. So the first one is, how long after commencing an SGLT2 do you ask for a blood test?
We would just routinely review them either 3 or 6 months. So looking at H1C, and if it's indicated, we would look at your kidney function as well, but it would just be a routine follow-up.
And then we've also got, should diabetic annual reviews include a simple liver fibrosis check, given how common MASLD is in this group?
Good question. Yeah, I agree. We're talking a lot about, the cardiovascular system, the renal system. So why not, screen for other things as well? Whether that can be incorporated into guidelines, then, that remains to be seen. But if you feel that there is an at risk, then absolutely, I would suggest screening as well.
Perfect. And then I think we've got some questions for the case study. So in the first case study, if you start SGLT2, would you stop glycoside? Which I definitely said.
Yes, good question. So especially with John being a delivery driver, so with glycoside, he would be needing to monitor his glucose levels every 2 hours in relation to his driving time as well. So that's a lot to ask someone as well. So if we can, give with one thing and take away with another, and sometimes that's a good motivator for patients as well. He's on very small dose of glycoside as well, so I would generally stop that and get them to monitor initially to make sure there's not a massive spike in their glucose levels. But it very much depends. If their H1C is a lot higher, and they're on, for example, maximum dose of glycoside, I may just reduce slightly and watch and see with monitoring. But with John, his H1C was on the lower side, and he was only on a small dose of glycoside, so I would stop that.
Perfect. I've also got, what happens if John or Benita experience recurrent urosepsis or thrush, worse, euglycemia, DKA, or foreigner's gangrene? Try my best.
So in terms of obviously the side effects associated with SGLT2s, thrush is about that education with our patient, make them aware that they are going to be peeing out a lot more glucose, so they do need to be aware of good hydration and good hygiene as well. I would normally treat the first UTI and reiterate the good hygiene, good hydration, and that generally clears up with most people. So it's about educating them, making them aware of the benefits of this, so that they can continue it. With the other side effects, so with foreigner's gangrene, decay, things like that, then that would contraindicate the use of SGLT2. So we would unfortunately not be able to continue with that. But then at that point, you're thinking we've tried an ACE on ARB, the contraindicated with SGLT2, their urinary ACR is raised. Let's try finerenone now. So we've always got that, right? Let's try plan B.
Perfect. I've got one from Suzanne. In your own MDT meetings, are hepatology involved?
They're not, no, unfortunately. Again, it's something that, you know, definitely there needs to be more research into, you know, that addition for the MDT. We've got the main players at the moment with the endocrinologists and the cardiologists and the kidney doctors as well. But, you know, we need to get everybody involved, and MDT means, you know, the more the merrier. But absolutely just needs to be more research into the benefits of including those people in.
Perfect. Then I think this might be more of a statement. I've got obviously SGLT2s should be offered to the majority, but sadly some people may be at disadvantage due to the risk of volume depletion or SEs such as UTIs and polyuria. I'm guessing kind of.
Yeah.
Perfect.
And we're still, you know, under treating people that, you know, if you look at the amount of people that could be offered SGLT2 but haven't been, you know, there is a massive gap across the country. So it is looking at those people as a whole, so going onto your dashboards, doing searches, and there will be people that, yeah, we can't start an SGLT2 in that person, but at least we've kind of had that look and put a reason behind why we're not starting that.
Perfect. Well, I think that is all of your questions. So thank you so much to Donna for delivering such an interesting and insightful webinar.